Good morning, Ms. Trainer.
Good morning, Willard.
Now, you've got 2 witnesses this morning?
I do, yes, Millard. I'm grateful.
Together.
Yes, I wonder if you could begin by saying your names, and we'll start with you, Mr. Soutar, if that's okay.
Yes, Sinclair Soutar.
And Stephen Warner.
Good morning, Mr. Soutar. Good morning, Mr. Warner.
Morning.
Morning.
Yes, Ms. Trainer.
Now, Mr. Soutar, as I understand it, you are the Chief Operating Officer of Kibble Education and Care Centre, is that right?
That's correct.
And Mr. Warner, you are Head of Corporate Services for the same organisation. And you both, I think, collectively, along with the help of some other members of staff, have prepared a statement for the inquiry. Now, for our benefit, that references SCI WT 0499, a dash, 5 zeros, and then a 1. That statement will be appearing on screen for you, hopefully to help you guide you through what we're going to be talking about today, but all of that information will form part of the evidence that the inquiry will consider. So hopefully we'll be able to touch on some of the more important aspects of that today. I wonder if you could begin perhaps by telling us a bit about Kibble and the services that it provides.
Yep, so Kibble Education Care Centre, our Paisley campus, as we call it, is obviously in Paisley. We've been there since 1859 on that same campus there, and then we have other supported services round about it. We cover a vast array of services across lots of different areas, all within children and young people. So we cover secure care, school care accommodation for both primary and secondary at 2 different campuses. And then we have community-based properties which support a slightly wider range. Most of them are aged 5 to 21, so that the care moves around the young person rather than the young person having to move with what school they go to. So from a residential perspective, we have 12 got 12 registrations, which gives us 29 care houses in total, supporting 134 young people through those services. We then have non-residential based services, one which are fostering service and adult placement service. So it's adult placement services in the terms of fostering, but when the foster young people get a little bit older and they can no longer be foster carers, so it's not a traditional adult placement services type. So we'll get 24 young people in there at the moment. And then we'll get housing support, which is us supporting young people in their own homes. And we'll currently get 5 young people in there at the moment. In addition to that, we have day provision of education across our schools, across our secondary school and our primary school, and our tertiary education. There's 23 young people in that at the moment. And then in addition to that, it's operated by our Kibble Works company, which is an associated company. We've got Puddle Lane Nursery, and that's registered for up to 56 young people. So quite a vast array of services across.
I think in your statement you tell us that you currently look after around 150 young people. Is that about right?
So it's slightly more than that. So it's about 134 from a residential perspective, then another 52 from non-residential. But those non-residential numbers fluctuate more, and we will have some vacancies across. So that would have been about the number at that time, and then it does go up and down depending on what's happening.
I see, and I think you also tell us at paragraph 7 you work with all 32 local authorities in Scotland, so a Scotland-wide service effectively.
Yes.
Next, I wonder if I could ask you about particularly about the users of the service. How many users do you have? Obviously, we've covered the people who are residing within the service, but is there a kind of wider population that you also serve? For example, kind of providing support services to care leavers, things like that?
We sometimes provide respite for young people, or outreach, I would probably say, as well, for young people that have moved on from the service, or, for example, could be working with our family service. That work could continue, and we'll sometimes support young people when they transition on from our services back to maybe another service or back to the home area, family home, etc. We'll continue that for an agreed plan, transition plan. That's done in partnership with the local authority, the child, the family, etc.
And is there a typical demographic of the service user?
What Steve's probably described it quite eloquently, the kind of complexity of everything we do from a nursery all the way through to the adult placement services. So our age range can go from 5 to 25. So there's not maybe an A-type, but what I'd say that, I think I'd referenced it as well, there's probably more of an increase in referrals in recent years of more of the neurodivergent population. So young people more with diagnosis, arriving more with a kind of mental health focus, and risk to self has probably been more emerging in recent years, and that's been a change. Maybe historically, say 20 years ago, it would have been more of a delinquent type population. During that time as well, I will say we changed from being all boys to becoming co-educational, introducing girls in the last 20 years as well.
And how do the children and young people who are within the service come to the organisation initially?
So predominantly, the vast majority of young people will arrive through the children's hearing system. We will have a small percentage of young people within our secure facility and the safe centre that will arrive via court proceedings, but that number has reduced significantly over the last 10-15 years.
You've told us a bit about how the services are divided, and I think you mentioned that there are various properties in which you have residential community-based placements. You also have, I think, a secure service, is that right? And are you able to tell us how many beds are within that secure service?
Yes, it's an 18-bed secure facility with an additional one emergency bedroom on top of that. So it's 19 in total.
You go on at paragraph 29 of your statement to also describe another service which you provide and I think has expanded in more recent years, which you term a specialist intervention service team. And you say that's effectively like a small specialist mental health team. And I wonder if you can describe what that is and what it does.
Yeah, that's headed up by our clinical director. And I think that's more or less in response to what I was saying there about the changing needs profile of the young people that we're working with, the neurodivergent population. So we've recognised that there's potentially sometimes gaps elsewhere in the sector. Access to sometimes CAMS, waiting list we know in the past has been lengthy. So we have always tried to be creative internally to see what we can provide, what disciplines that we can add that will help to support that kind of care needs package that we can provide to young people. So it's broken down, as I say, a number of different disciplines within there. It could be speech and language therapy, clinical psychology, forensic psychs, different therapists, different counselling services, all within the SIS team, and it has expanded from only a relatively small team to more than 20 full-time equivalent today.
I'm getting a sense that there are a very wide range of services that the organisation provides, and I think you tell us at paragraph 22 of your statement that in your view the organisation is unique insofar as it can provide services from birth, early years to mid-20s, and that perhaps offers some continuity for children and young people who come to you. I wonder if you can tell me a little bit more about that, how your service is unique.
Yes, there's not many. Steve had mentioned the word campus. We operate a campus model, and that in itself is quite unique. In Scotland, probably the wider UK, there's not many childcare services that work within a campus model, and that's something that is developed over time gradually. We never had a secure facility when I started working in Kibble, and that's something we've added. We've added other houses as we've grown. Probably the biggest growth has been out into the community and recognition that we need to do more in terms of geographically that spread, getting young people back out in preparation for moving back into their own communities and working with the local community. So there's been a huge growth area in there, but for us that continuity and that consistency is really, really important for the young people. And what makes it unique is a young person could arrive with us in one service and they could they could transition on to 2 or 3 different services throughout their journey, and they could be with us for not just a year or two. Some young people, it's not been unusual in the past to remain with us for 5, 6, 7 years. And also during that time, if that was the requirement was there, they could have some of the same key team that are working with that young people could remain with them and transition with them throughout that journey as well. So that does make it unique. We're not a standalone secure care facility, a standalone residential. There's a whole array of services there that can offer that continuity.
I think you mentioned within your statement at paragraph 28 that it's not an unusual circumstance for you to have staff who are working within one service, and because a young person has moved on, they too will also move on with that young person.
Yeah, that's happened in the past, and you don't work for the service you work in, you work for the organisation, you work for Kibble, and everyone's familiar with that, is that at the end of the day it's about the young people, why we're there, and what their needs are. We need to try and support that, so we will put whatever we can in place to try and make that as smooth, as productive, and create the best outcomes. And sometimes that is that someone, it doesn't always have to be the key worker or the key person that's working. It could be someone else, that the relationships there, as we know, is so important. And sometimes the young people don't want anyone to transition with them, so it's really needs-led, needs-based, and listening to what the young people want.
That sort of move in services is what's led to a lot of the service development. So a lot of the new services we've created has been around the need of the young. The housing support service is a perfect example. We've got very, very low numbers in that. That was designed around some young people in some of our community-based properties who were struggling to get their own tenancies. So we developed the housing support service. The staff moved with them across to that, and now they're living in their own homes. A number of them are now transitioned completely out of, with no support from Kibble at all anymore. So it wasn't designed because we wanted to run a housing support service. It was a need for that young person and that group of young people we had. And that's where the service development comes from.
I wondered, because you work with all of the local authorities, but of course have a campus-based model, does that mean that predominantly you work with the majority of children from the west of Scotland rather than from a wider geographical area?
No. We receive referrals from the length and breadth of the country, so young people from as far as you could go, Shetland Islands, down to borders, so all over we work. Sometimes that's an assumption that's made because of where we're based, in Paisley and predominantly in Renfrewshire, but no, the majority of referrals are actually from local authorities further afield, but that can change.
I want to go on to discuss, of course, the pandemic, but really what you term in your statement as pre-pandemic planning. And you discuss that you as an organisation, perhaps quite unusually, did have crisis management plans in place. And that seems to be a positive theme which runs through what you say in your statement, that those plans really were invaluable in setting you up for an unexpected event like a pandemic. I wonder if you can tell me, in terms of crisis management plans, what do you mean by that and how did it come about?
Okay, I think in 2014, roughly, we had recognised that there was maybe a gap or something there that we had to develop. We had an existing risk register for the organisation, and at that time we brought in an external consultant to work with the senior team, so that predates Steve and I's time on the senior team. However, we were involved in the organisation at that time, myself as a middle manager, and we set out and reviewing policies and creating new policies, organisational resilience, and what would fall under that would be business continuity, enterprise risk management, and what followed from that was a series of different training events, tabletop exercises, plans that were contingency plans in the eventuality if something was to happen in line with the risk register at that time. We actually reviewed the risk register and reduced it as well down to 10 strategic risks. And we had, I say, a lot of plans, contingencies where we focused more on the effect and not the cause. And when it came to the pandemic, we didn't have a specific plan for COVID. We had a specific plan for example, a loss of staff, and what we would do for that, and what our contingency plans. So we were well versed. We had done a range of tabletop exercises, not just as a senior team, but also the middle management team and beyond, across all the different services and different sites, looking at various things. But we knew that we had things in place that allowed us to prepare and plan what our steps would be if something was to hit that would affect our staffing like COVID did. I mean, you right away that the first step we would go to be looking at our teaching staff with the contracts would facilitate a move for them to support care staff. Next step would be specialist interventions, service staff going in and supporting as well. And over and above that, we had a number of different other kind of plans that we could put in place, and we did a lot of Brexit planning as well, which stood us in good stead when it came to the pandemic.
I think in terms of that Brexit planning, you say at paragraph 39 of your statement that that planning particularly had meant you stocked up on electronic equipment and things like food supplies and first aid supplies, and that really helped you.
We were planning for shortages. We were planning for Brexit being the reason for the shortages and being able to get IT equipment, food, first aid, and that was kind of where it. So we were focusing on, that comes back to that, the effect. We were focusing on supplies not being available. What caused the supplies to be available was almost irrelevant as far as the planning is concerned.
An example of that, which I thought was interesting at paragraph 42, is I think you say, actually to you it didn't matter what the problem was. It could have been industrial action, it could have been that all your staff won the lottery in a syndicate and just went away one day. The fact was that you planned for not having staff present, and there were processes in place. You knew where you were going to go next.
Yeah, we were well versed in terms of what, as I say, what the steps would be. We knew where we had to go and how we could support. Because the priority was, our objectives never changed. The priority first and foremost was to keep the young people, staff, visitors safe. That was the kind of key objective at that particular time, and we knew that what we had to do is look at how we can bolster and support the care staff to support the young people.
In terms of the actual steps the organisation had to take quite quickly as a response to the pandemic, at paragraph 59 you mention there was a recognition that the senior leadership team particularly needed to be visible because all of the workers also continued to have to keep working throughout the whole working week, or the whole week rather than just the working week. So you say you moved to a 5/7 rota so that you were in on weekends as well as the staff. And I wondered how you think that benefited the organisation.
Yeah, I think that at the time, I think it was a bit unusual. I think staff were surprised to see us there, because generally we would work Monday to Friday, but we felt it was important given that the issues were arising at any given time, weekends, nights, whenever. So we thought for that kind of leadership, for that visibility, to let people, the message I suppose to staff was that we're all in it together, we're here, we're not going to be sitting at home. So we were allocated, it was myself that devised the rota for that, and we allocated into kind of smaller teams and smaller pods of 2s generally, and so that we weren't all working together at the same time, and so some people working from home and some people were in there. But I think what that allowed us to do was to be on hand for any queries, any concerns, to meet with any staff, take any calls, do it virtually or socially distanced, but we're all in the building. So my office is still within the secure facility. So I was still in that building every day I was on the campus at that time, and yeah, I think there was benefits to that. It took a wee bit of time for people to get used to seeing us being around at weekends and things, but it was certainly, I think, beneficial.
Has it continued post-pandemic?
No, it continued for a period. I think there's a lot of things that we have continued that have been there to stay, but we reviewed that at a certain time, because of course when things went back and changed a bit, predominantly a lot of our business needs will have to be around Monday to Friday, because that's when a lot of the meetings are and different things are taking place. So, but no, we kept it in for quite a lengthy period of time, and we reviewed it constantly, and then there was a time I think we gradually phased it out, and that made sense. But we still have an on-call system, a senior on-call system, 24/7, 7 days a week. So that's.
Moving on to paragraph 62, you talk about recognising that the majority of your staff, first of all, had to be in person, but also were defined as essential and key workers. But they obviously had their own families, their own needs, and needed childcare. So the organisation took steps to try and alleviate that problem. I wonder if you can tell me a little bit about what you did.
So one of the bits we recognised quite early on was obviously our staff got different places for their own children within the schools hubs and things like that, but they didn't fit in with the shift patterns. So a lot of the schools were open 9 till 3. That doesn't really help. So we recognised that, and we worked very closely and very quickly with the Care Inspectorate and Fire Scotland and things like that to get what we called schools out set up over at our Hillington facility, which had the space. It already had a soft play area. the laser tag area. It had lots of activities there already, and what that allowed us to do was staff that with our own teachers, but it allowed the staff to bring their young people in, leave them with essentially people they knew and people who were fully qualified and trained to run a school anyway, and allowed them to come into so I think at one point, or at the most, we had about 50 young people across the week, not at the one time, but 50 young people across the 1 week of staff's children who were attending that, which essentially freed up, if we man that with 10 teachers as an example, it frees up 50 staff to then feed into the rota within the main campus and within the rest of our community-based services to keep things running. I think, as we mentioned earlier, staffing was our biggest. It has always been, loss of staff has always been our highest point on our risk register, long before COVID, and it remains there. We require staff to run our services. That's how it works. So therefore, ensuring the staff were there meant that we could keep things running.
You mentioned, I think, one issue being that the key worker hub facilities would not fit with shift patterns of your workers. One of the other things you mentioned, I think, at paragraph 64 is that there were some people who couldn't get places.
Yeah, there were limitations. But obviously, with us being based in Renfrewshire, you've got some of the largest hospitals in Scotland there. You've got some of the so you have a lot of key workers, I suppose, looking for places at that. So if we could alleviate that and run our own version of it, then it kept things running for us.
And it was an area, so that the area that we developed, this kind of schools out hub, we called it at that particular time, was an existing building or service that we had under our umbrella, and we recognised quite quickly that there was something that we could do that would need a wee bit of investment and a bit of tweaking, but we could create something that would be quite bespoke to support the staff and offer it. We worked with the Care Inspectorate to get registration quite quickly, and our host authority at Renfrewshire Council, so worked in partnership with them, and they recognised the need and could see the benefit of that as well. So it was up and running really quickly, and staff, I think, were certainly appreciative of it as well. It allowed them to get to work, so it was a kind of win-win.
And again, has that service continued after the pandemic?
It hasn't continued as schools out, but it has converted over to Puddle Lane, which is now a nursery. So that was essentially what that fed over into, that need for, I suppose, a nursery provision that could fit in around shifts, or could fit in around you need 3 days this week, 4 days next week, that sort of shift pattern system, rather than a traditional, you need a Monday to Friday, 8 to 4 nursery placement. And
that's also for staff, also the wider community and public as well, so that's a shift, it's a change, because when it was the hub, it was just for Kibble staff, but now it's further than that.
I suppose the important thing to mention is it's just a mainstream nursery, so it's not, when we talk about other Kibble young people at our services, it's not, it's just a normal mainstream traditional nursery.
You mentioned, in terms of the crisis management planning that you already discussed, that there was a plan for staff to be redeployed. And at paragraph 69, you talk particularly about staff being redeployed during the pandemic, but I wondered if you could kind of outline, it may be obvious, but why that was immediately necessary and why it continued to be necessary.
Well, particularly at the start, with a number of staff, there's a lot of unknowns as well at the start, and a lot of staff were reporting with symptoms, some with concerns. So quite quickly, we noticed that there was staffing numbers were dropping, we were having some absent from work, so we recognised that we would have to look at that contingency quite quickly. And I'd mentioned it was our education staff that would be identified as the first step to go in and support some of the houses. I think we tried to do it at first. There was a gradual recognition. It wasn't something that we would have jumped right into, but when we saw the numbers starting to spike in terms of the care staff absence levels, that's when we knew that, I can't remember the exact trigger point, but we knew as an organisation that we had to press the button and get the staff in there to ensure that the staffing levels were adequate and they were safe, and that the young people were getting the right support that they required at that particular time, because the young people naturally had anxieties as well.
You discuss the kind of use of bubbles, and at paragraph 73, that I think is something that you mention. I wondered, in particular in relation to residential units and secure units. Were there changes made to staff and to rotas so that effectively for a period some staff lived in the provision?
So no staff lived in the provision, so it was very much just a case of, it was that segregation. One of the biggest risks, I think, was the close contact. Rather than the people who were necessarily ill with symptoms, it was the close contact. So if you had, so we would keep different shift sides apart, so that if somebody was ill, it would only affect that one side of it. We would limit the mixing between the services, because what we didn't want was we didn't want that contagion. If you've got a staff member who's worked 3 or 4 shifts across 3 or 4 houses, you then ended up with a close contact list that could run to 40, 50 staff. So it was that very much that. That was the same, Sinclair mentioned it earlier, we talked about the senior team working. We worked in bubbles as well. We never met physically, the two sides of the teams, for a long time, so that if you lost people, you didn't lose all of your knowledge, all of your skills, all of that sort of thing at the time. That was how the houses were set up. Originally they worked as single houses, and then eventually we moved on to what we called sister houses, so most of our houses have neighbours, and then they work together as a team.
I think it's fair to say the staff, a lot of the staff went above and beyond, and there might be examples of, rather than actually sleeping or staying in the house, that the staff remained way beyond their shift time, finishing time, or worked a double shift to support if something had come up during that point. So they were really supportive of each other. I suppose we were also supportive of them. We had to look out for staff who were maybe doing a lot more shifts as part of the bubbles, and you're looking always at the concern around about burnout or compassion fatigue as well. So I think there's times we had to intervene and try and support in different ways as well, maybe introduce someone into a bubble and they had to then remain in that bubble in order to tap someone out. So it worked in different ways, but it was beneficial being able to operate like that as well, for that continuity.
You go on, and I think there's a heading within your statement of guidance, and at paragraph 81 you say that you initially had to navigate guidance for residential care, which in your view was really about adult and elderly residential care rather than for the childcare sector. And I wondered if you could tell me more about that and where you think perhaps the guidance should have differed between the two sections of the population.
Yes, I think some of the initial guidance that came out was quite generic, and I think it was probably more older people centric. I think there was maybe a feeling that a lot of it was, and some of it was transferable, but I think there was differences probably for the care home settings, the younger children. There was things that come out that, if you use some examples, would be like physical distancing. When you're working with 5 and 6 and 7 year olds who can be very tactile and they're all over the top of you, and really physical touch, not just for the younger kids but for a lot of our older kids, touch is really, really important. It can be soothing, it could be nurturing for them. So physical distancing wasn't always feasible or even possible in these environments, and some of our environments are very intensive, whether it be secure care. We have environments that are known to be called intensive support services as well, kids with additional support needs. So physical distancing could be a challenge, but there was also other things round about. Even if you think about some of the PPE, the wearing of face masks, a lot of our young people can be non-verbal, or they can struggle. Neurodivergent population, they rely a lot on facial expression, body movement. All these things are really important. So face masks were not really something that we thought were going to be appropriate for our settings, and even simple things like alcohol hand gels and things like that, we couldn't have them around because there was a risk of young people just simply alcohol based, lifting and drinking them or using them to do other things. So simple wee things that we had to do. We had to have our own tweaks and variations, but we were able to, we're fortunate, we were part of different forums and different groups. We were able to share quite quickly some of our concerns or things that we felt had to change for our particular settings, and a lot of these things did happen, but maybe not, it just took a bit of time.
There was also a lot of complexity in them. There was lots of, so staff are watching news reports at night, social media, the different rules that are about. We work across all the local authorities, so you might have slightly different lockdown rules in different local authorities the staff might be travelling from, that kind of thing. So a lot of our own paperwork internally, which had to change very quickly, was very much, the guidance says A, but this is what it means in the service you work in, to try and put it into a bit more shorter bullet points, a bit more succinct. You know, this means blah, rather than here's the massive paragraph from the guidance.
I'd give Steve credit for that. He did a lot of that interpretation, and it was really helpful because staff were then able to understand, okay, this is exactly what it means for us. And even when we went to the roadmaps and things, we broke it down to the areas that we were working in as well to make sure that people were clear what was allowed, what was not allowed.
Maybe a question perhaps for you, Mr. Warner, then, that in paragraph 88 of the statement you talk about there being lots of pages of guidance and policy, and you describe that as being at times difficult and challenging. And I wondered if you had any views or reflections on the guidance which was provided and perhaps how often it then changed.
I think it changed very quickly. So by the time, if guidance changed at 5 o'clock at night, we were then, Sinclair spoke quite a lot late on at night, most nights, working out, right, this is what it's going to mean for us. So by the following morning, we had new guidance out for staff in Kibble as they were going along. So it was that very much, that sort of very quickly, what's changed, what's happened, once the initial version was created of our guidance. Written in, I suppose, the same sort of format and style that our staff are used to for normal policy and guidance that we have at the moment. We then just kept adapting that. Sometimes you had the same guidance for a week and a half. Sometimes you felt as if you were changing the guidance almost daily at some point. Sometimes they were big changes, sometimes they were smaller. It started to become a bit more complicated when different local authorities had slightly different rules, when it was different lockdowns and different things like that, because it could be staff travelling from where they live, having different rooms, or our young people going to visit family through different local authorities as well. So it was just trying to navigate all of that was complicated at times.
And I presume that some of because you deal with various different local authorities, some children will effectively be supervised by social workers from varying local authorities, and those are taking different approaches as well.
Taking different approaches, different rules, that sort of thing.
At paragraph 86, you say that there's lots of things that you had to consider for the kids that you support, and you've discussed, of course, kind of face masks and touch, things like that. But you say that there were some exemptions, I think, to the guidance for the children which are within your care, particularly the young people who have underlying health issues. And I wondered what exemptions you're referring to there.
I think it's really just what we're saying in terms of the face masks and different things. That can't remember some specific examples, but I do remember that there was exemptions made for our service because of the complexity, for example, within secure care, not just for the underlying health issues, but also for the nature of the environment. We didn't think it would be conducive for people to be wearing face masks in the secure environment as well. So there were exemptions that were made, not even just for ourselves, but for different settings. We operated probably a different model in maybe our early years service to our older young persons residential, and that could differ from the secure care. So it was very complex in terms of how we could navigate and manage some of that. And there was, again, as I say, some young people with the health needs, younger kids being non-verbal, for example, there would be different, based on their individual needs, there would be different things put in place.
There was simple things like, depending on the risks in the houses or the safe centre, as was a specific example, we had to count PPE in and out, because a mask going missing which has elastic in it becomes a ligature, it becomes a, so there was lots of rules around things like that. So the safe centre, as an example, we didn't use face masks at all unless we were dealing with a young person with symptoms, because the risk of the face masks being left or discarded, or the metal bridges that were in some of the face masks could be used for self-harm and things like that as well. So there was those kinds of, where we talk about safeguarding, where it was more risky to have the face masks there, the face coverings there, than it was to not have them.
One of the challenges I think that you talk about at paragraph 92, particular to children in secure care, was testing, and how when there weren't tests available at home, how they would be tested and how that would all work. I wondered, did you end up having to do that, and how was it managed if you did?
Yes, I think we mentioned in the paragraph that our location certainly helped, given that the testing station was set up at Glasgow Airport and it was only a 5-minute drive away. And I do actually remember the first time we had to take a young person out from the safe centre out to a testing station, and that going back to what I was saying about being in the building and visible and leading, I supported that personally for a young person who was placed with us through court proceedings, so quite a high profile case. So we were there, and three of us, someone to drive and two of us in full PPE at that time. It was very early on. We had the full suit, everything on to protect the young person, and we took the young person over, supported through the whole testing process. He was a credit, and we returned without any issue. But gradually, as things moved on, we got better through that. We used our contacts through public health, through health. We were able to voice some of our concerns, because that transportation to get at a time where probably that was mentioned with staff, obviously issues or whatever was going on at that time, to then have to find 3 people every time we had to get a young person out to be tested. So fortunately through time the postal tests came in, and that made it a lot easier to manage, rather than having to transport a young person out every single time, because that could be distressing for them as well.
You go on to discuss at paragraph 112 that there was a payment by your organisation to the workers, but also that there was a payment by the Scottish Government to health and social care staff who were on the front line. I wondered, did that payment cover all of your staff members?
Good question.
We paid it to all of our staff members. I would have to check with finance as to whether it was recovered for all of our staff members. I believe it was, but I wouldn't want to say categorically.
I then wanted to touch on the issue of local authorities. You go on there at paragraph 113 to discuss your close relationship with local authorities, which I think comes about by virtue of the fact that the children are placed by the local authorities into the organisation. You say at the next paragraph, I think, that the engagement with local authorities and the engagement with social workers, particularly with the young people, went really well. I wondered if you felt that children and families, social workers, were as visible during the pandemic as they were pre-pandemic.
I'd probably say there might have been a slight reduction in some of that. I think the contact was still maintained for the most part. I think social workers at the time, I think, like everyone, they would have been extremely busy dealing with various different things in their caseloads at that time. But I think for ourselves, I can't say there was a significant reduction or they were less visible. I think when they needed to be there for particular meetings, a lot of our meetings switched to being virtual anyway, but if there was a necessary face-to-face contact, we would have facilitated that as well, because it was classed, I think, essential was how we had termed that as well. So we said anything that was happening that needed to be essential contact with professionals, then it had to happen. We facilitated that, so there was no barriers to that taking place. It might have just been that the social workers would have switched for the non-essential contact, just for touch and base, whatever, that would have still taken place. We didn't have too many issues or concerns about that, and if we did, we would have advocated or raised that or spoken to the appropriate people to raise it.
I suppose one of the advantages we have with the group of young people we work with is that technology is not alien. You know, you might have, I suppose, that opposite issue when you go to the elderly, not want to typecast things, but our young people were sort of used to that, the video chats, whether it was Snapchat, so we very quickly moved to having phones and tablets in the houses, so they could use FaceTime, WhatsApp, we could use Teams. It was with local authorities, we could use Zoom, so we had those devices in all the houses very quickly, very early on. And that's one of the things when we talk about the stuff that's remained. That wasn't there. We had rooms with video conferencing equipment before COVID, but we moved very quickly to having it everywhere, and that's kind of remained. So if young people now want to FaceTime with their families, they can do. The equipment's now there in all the houses for that. So that's one of those things that was brought in for the pandemic and has remained.
But when a young person's placed with us, that whole continuity and what we can offer is that kind of all-inclusive service. So that can be quite reassuring, the young person, in terms of their care needs, their education needs, their further support needs round about counselling, psychology, whatever. We take care of all of that as well, so I suppose there's probably less of a need for social work intervention to come in and facilitate or transport. I think that's one of the benefits of having that campus model, is that everything's all under the one roof, so there's not any extra transitions or extra supports that are required. We can provide everything all in-house, so it would just be the young person needing the contact or support for anything that's over and above the kind of statutory processes for reviews and hearings and things, etc., which would need multi-agency involvement. But we would always work in partnership with the full local authorities multi-agency team. All of our meetings would be multi-agency focused as well, so all discussions, nothing would be made in isolation.
And those multi-agency meetings, in your view, continue to happen? Yes.
Might not have been as frequently, but they still continued. The key decisions, the key conversations all continued to take place round about young people's care plan and their child's plan. That had to happen.
You also discuss at paragraph 115 that during that period, young people arrived and young people moved on. And I wondered if you had any sense of whether that was the same numbers of arrivals and people moving on, and also whether it was the same speed of transition through services, or whether that reduced or slowed down in any way.
What I would probably say to that is that a lot of the time when young people need to access our services, it's really general as an emergency nature to that, and more often than not, when they require access or are referred in, it's quite quick that placement is needed. I don't recall any real change to that. It's still been the same. Maybe never had huge numbers during that period, but we still had young people coming in and young people moving on, but nothing that sticks out as in terms of how many we had or how many young people were moving on, but we still continued to operate in terms of being open to referrals and young people continuing with transition plans within that.
That perhaps leads me to asking you about the children's hearing and court systems, which you are involved with by necessity because children are on legal orders quite often placed with you. At paragraph 120, you talk about there being an extension placed on compulsory supervision orders. I think that extension was in place because of legislation, emergency legislation, which was enacted. You say effectively that the processes were made more flexible, and the extension of compulsory supervision orders is one of those examples of it being more flexible. I wondered if in a circumstance where somebody needed emergency placement or needed a review of placement, something like that, do you know whether that it was able to happen as quickly as it did pre-pandemic?
We had no experience of that. However, talking from experience, if there was something that was of an emergency nature, then we would certainly be flagging that and advocating for that to happen. And of course, if it was something that was of that kind of magnitude or it was serious enough, then I would be confident that would take place, that people would be listening, particularly if it was a young person, for example, in secure care, where they should only be there for the shortest period of time that's required for them. So that there would be different, as I say, responses for different settings, but if there's an emergency nature and there's a young person in distress or crisis or there's a need there, then I would be confident that would have still taken place, although we didn't have the experience of that, fortunately. We didn't have to do it.
You then go on to discuss that I think children's hearings is something which you have the most contact with rather than courts, and those went to being virtual. And you say both children's hearings and your experience of court appearances, some of the stuff that was virtual is still around at this moment in time. What is your view on whether we should revert back or whether some of the stuff should continue to be online?
I suppose my view always revert to listening to what the young people want, and I think some young people, Steve said there, they're not alien to using some of the new technology, and they embraced that. And I think the pandemic certainly accelerated some of our movement to becoming digital, so that was a benefit. But I would listen to what the young people want. I think still closely linked in with a lot of our young people today, and some of them still enjoy it being virtual, but some of them don't enjoy it. They prefer the face-to-face. I think if you think of some of the neurodivergent young people we have, they can be easily overstimulated, and some of them are not as comfortable maybe engaging with some of the virtual methods. So you have to then look at alternatives for that. But it's really about listening to what the young people, that can vary. Some will still want it to be there, some won't, and that's just natural.
I suppose perhaps on a more tailored basis rather than it being a blanket virtual or a blanket in person.
Absolutely, yeah. So as I say, it would be individualised in terms of how we'd want to do that. Of course, as I say, we've got young people who are from the very north of Scotland and maybe having to travel 3 or 4 hours to go to a children's hearing that lasts longer than an hour, then travel 3 or 4 hours back. There's benefits there because that journey can be quite difficult for some young people as well. So there could be benefits there for doing that virtually and not having to travel. We used to, probably pre-pandemic, talking about secure care, hold a lot of children's hearings in the secure care facility. Post-pandemic, we've hardly had any, so things have changed up a wee bit. As I say, some of that's for the better as well, though.
That decision perhaps to not host the hearings within the secure setting, was that at your instance or at the local authority or at the Children's Reporter? Who makes those decisions? It
wasn't our instance. I don't actually know who made that decision, but it certainly wasn't our decision.
Did you see that, holding them within the unit, as something which at times was beneficial to some of the young people?
I think some young people would say they did. Again, it would be a mixed feedback on that. Some young people would say that they enjoyed that people were coming to see them and visit them and see the environment that they were staying in as well. There was benefits to that. So, as I say, some young people enjoy going out and into the children's hearing centres or going back to the local community. It can be mixed feedback on that.
You mentioned the issue of parental contact within your statement a few times, and I think you tell us very early on at paragraph 52 that you, in relation particularly to secure care, one of the actions that the organisation took is to continue that contact because you were able to build a facility outside. So contact could take place outside with birth families. Are you aware if that allowed parental contact to continue at the same frequency for the children within the service, or for some did it stop?
No, it allowed it to continue at the same frequency. We were quite creative, and we recognise, I think, having that contact with families, with parents, with the team around the child is really, really crucial for the young people. So we recognised it was something we had to create, not just within the secure care. We created an outdoor bespoke space that would allow us to facilitate that. We also did it within the residential campus as well, and we also had designated areas within some of our community settings, and even in the foster settings as well. We had garden space that we could utilise to promote and facilitate contact with family and extended family carers and friends, etc. So that was across all the settings that we looked at specific areas where we could facilitate that to happen, because we knew, again, listening to our young people, we knew that was crucial.
You also say there was a discussion, I think this is at paragraph 58 of your statement, that for some people who were at home or on a home visit when the lockdown was announced, it was agreed that they would stay within that home setting.
There were some examples where young people were at home and someone within the family home had maybe tested positive or had shown symptoms, and the family or the young person would get in contact to let us know, and we would have, again, in conversation and partnership with the family, with the young person, with the local authority, to make a decision on what was the safest thing to do at that particular time. And on some occasions, the safest thing was for that young person to remain at home, and then we would arrange the young person to be transported back safely to ourselves when that time was right. It didn't happen lots and lots of times, but it did happen on occasion. And
when you're discussing that, I take it from what you're saying that you mean perhaps on a temporary basis rather than on a permanent basis?
Absolutely, on a temporary basis. You'd be talking until maybe there was maybe a testing process had been concluded, or the symptoms had gone away, or yeah, it was absolutely on a temporary basis.
At paragraph 87, you discuss, again, parental contact insofar as you say that through local conversations before guidance came out that you were aware that the children within the service would be allowed to have family contact. So in effect, they'd be exempt from the prohibition of contact between people from different households, for example. I wondered, how did you know that information and who told you that?
I sat in, there's a couple of forums that some of the senior leaders were part of, some Scottish Government-led forums, multi-agency forums, where, for example, it had representation from the Office of Chief Social Work Officers, and we knew that some of these things were certainly being considered, and I think a lot of that goes back to what I'd mentioned earlier, was in response to things that we were flagging about the guidance and saying, well, these young people really need to see their families. It's probably the single most important thing that they will say for them. So we were feeding a lot of these issues or concerns or queries back, and so we knew quite early on that that was, that's one example, but it was being recognised, it was being listened to, and we found out that was going to happen, is that young people were going to be allowed to have contact with some of the safeguards and things in place that we had to facilitate. So we knew, I think, quite early on that it was going to happen.
Were there any discrepancies in approach between local authorities on the issue of parental contact?
Not that I'm aware of. I think everyone was in agreement it was important for that to happen.
Could it always happen or was it always permitted to happen in a physical sense, in a direct contact sense, or were there times when it was deemed that it had to go, for example, online or be by telephone?
The only time it would really have gone online would have been if a young person was due to family contact and then there was an outbreak within that family home, that kind of thing. We would switch that to online at that point, but that would be the only reason for it.
There'd be different individual circumstances for different kids. Out with even the pandemic, we facilitate virtual contact for children's extended family who are different settings, different parts of the world, that we have to be creative round about as well. So that's really nothing new for us in terms of having to find a solution to that. But during the pandemic, again, it was just another area that we had to try and be creative and facilitate. We would always do that, even if it was a family was struggling to come and visit. If they couldn't afford it, we would work with the local authority to try and put supports in place to get the family there or get the young person to the family.
I wondered if I could move on from the issue of contact to talk about mental health, because that's an issue you particularly raise, and we've already spoken, I think, about the Specialist Intervention Service. But at paragraph 134, again, you talk about mental health. Are you able to describe whether the organisation saw an impact on the mental health of children and young people because of or during the time of the pandemic?
I think what you probably see, I think I'd mentioned earlier, there was certainly at different points an increase in anxiety for some young people. Maybe around, it could be about worrying about extended family members. I think everyone was seeing what was reported in the media at the time, round about mortality rates increasing, round about the spread of the virus, the different lockdowns. And I think there's no doubt that there was anxiety inducing for some young people. They struggled with some of that as well, but again, we had to put supports in place with them. And I think any change to young people's routine as well, and I think we spoke about putting bubbles in place and the kids not being allowed to mix as part of that. Some of them struggled with that as well, not mixing with peers and other services or other houses, because even within different stages of education went to different zones and the houses all operated within their own bubble. So some of the young people struggled with that and not maybe getting to socialise with some of the other peers, although they would still be socialising with peers within their own house. There was different parts, but on the whole, a lot of the young people within our setting, I think, given again the campus model, a lot of them showed remarkable resilience and were feeling contained, and the staff did a great job. We put lots of things in place to keep them active. We added to different outdoor space, not just to facilitate family contact. We actually built like an outdoor all-weather sports surface. We created all sorts of different things that we could do to try and make it, as I say, as smooth as best as we possibly could for the young people. But there's no doubt that individual young people would have struggled at different points with different things. That change can be, obviously I'd said the sensory changes as well, but yeah, not being able to mix was something that was frequently said, but again, we were able to facilitate that contact in different other ways as well.
I wondered if you have, whether, I don't know if it's too early to say, but if you have seen a long-lasting impact on mental health as a result of some of the restrictions.
I think it probably is too early to say. What I would say, and I had mentioned earlier that the needs profile of our young people has changed, and I don't think the level of complexity is reduced. I would probably say the level of complexity is increasing, but I can't sit here and say that's as a result of the pandemic or what happened over that period. But certainly the referral and the needs profile of the young people that we are working with has a different level of complexity there as well, and there's more of a need for mental health supports than there ever has been, and hence why we've increased and responded to that by adding additional services and additional layers to our specialist intervention service.
You go on to discuss some of the other impacts which you saw in terms of the young people throughout the pandemic period, and you, paragraph 139, talk about absconsion from services, and I think that is generally just an issue within, has always been an issue within residential services. You discuss that continuing to happen during the pandemic, but perhaps at a lower level. I wonder if you can tell us a bit about that.
Yeah, I think there was certainly I go back to what was reported in the media and what was there. Young people were seeing that. They're very active on social media these days, and there was maybe a level of fear there that young people, that they didn't know what was going on there in the outside world, looking beyond our campus, or if they're in the community, what was happening in the wider community. So there was an element of fear. There maybe also wasn't the same level of attraction. There wasn't anything happening in the communities. As you say, at different points we were in lockdown, there wasn't that go-to place for them. They knew a lot of their peers were still operating in their own bubbles. So there is no doubt that the level of young people absconding or going missing for ourselves reduced during that period. Probably as different as things started to lift, and there was further movement out in the communities, there was probably a bit of young people were maybe intrigued to see what was happening, to get out there and investigate for themselves. So there was a bit of that around, which is only natural as well. And I suppose after a period of time, if anyone is experiencing a lockdown or been in a bubble, I think everyone, when there was the opportunity to do so, to get out and about, I think a lot of people were keen to do that, and our young people were no different.
Are you aware of any children or young people receiving financial penalties as a result of breaching restrictions?
No.
You go on at paragraph 43 to discuss the response of young people to vaccination, and you say that the response was mixed. I wondered if you could tell us about some of the reasons that young people cited for an inclination perhaps not to be vaccinated.
I think some young people, there was probably various reasons. There was some young people who had simply had a fear around about needles. We did our very best through the care team, through our nurses, to try and educate, try and support and try and encourage, but ultimately it was down to the young person's choice. Also, some young people were influenced. There could be an influence by their peers saying don't get it. I think they were also, again, they would have been reading and seeing and hearing what was being reported as well in the media, and maybe some family members had a view as well, and sometimes the young people adopt that view. Again, that's pretty natural, but yeah, it was quite simple. Some young people, maybe on the day, they just chose they didn't want to do it, they would rather do something else instead. It could be something as simple as that, they chose to do what they want to do. But yeah, it was a mixed response, but on the whole, a lot of our young people did respond positively to it, and to their credit, yeah, they did engage in the process.
You also discuss at paragraph 145, sometimes there being frustration for different family members about interpretation of guidance. Can you recall any examples of that, of what you meant by that?
Not really. I think some of the family members would like to have visited at times maybe more often. I think at that particular time we only had designated spaces, so we couldn't have everybody in at the one time. Normally we could facilitate a number of families at any given time, but when we only had one space or two, 3 spaces, 4 spaces across all the services, we could only have one visit in at a time. And I think there was some natural frustrations round about that, but we had it blocked out every day for full days for the full week. So we were trying to work and be as creative and supportive as we can and facilitate it. And if people were travelling longer distances, for example, we would allocate a wee bit longer time for that. I think that's only fair if people were coming a longer distance, or we would even say if they were staying down in the local area, that was possible, that they could come back the next day and we facilitate it again. But yeah, I think people would like to have had maybe a longer time, but we had to allocate it in slots. But on the whole, yeah, there would have been some frustrations around about that particular time, some around the guidance, some people wanting to have more face-to-face or even in the building or whatever, but we had to put safeguards and measure in place for every other young person. We weren't just looking at one young person in silo. We had to consider everybody's needs, and again, we would always sit down and explain the rationale and decision making behind that to families to help them understand. I think for the most part they did.
The other impact you had there was obviously different local authorities, maybe having some local authorities being in lockdown, other local authorities not being. So if we were in lockdown in Renfrewshire, but a young person's family were coming from Dundee that wasn't, you had that difference, and you had an actual physical difference in the rules between where they stayed and where the young person was.
Yeah, and there might have been a local authority, Eastern Bartonshire, Western Bartonshire, in lockdown at a particular time, and the contact was meant to take place in that area. You'd have to say, well, no, we can't now do it, we'll have to switch to virtual, or can you come to us? And that would cause a frustration as well.
Moving towards the end of your statement, you talk about some of the lessons that your organisation learned in terms of the pandemic, and particularly you talk about the crisis management practices that you had in place being very helpful. Generally, I think the tenor that I got from your statement is that, of course, it was unexpected, but your experience was largely quite positive. Is that fair?
I think we recognised that it was a difficult time. There were lots of challenges. How I would describe it is that we did benefit, and we were fortunate that we had those existing policies and practices and understanding in place, and that certainly helped us to manage and navigate through what was still a difficult time, but it stood us in good stead.
You've narrated the lessons that your organisation learned, which is helpful for us to be aware of. Do you have any lessons that you think might be helpful for decision makers to learn as a result of the experiences of your organisation?
Well, I think we've already covered the part about having pre-existing. I think you can never have too many contingency plans or plan B, but involving people at all levels within organisations is certainly beneficial in terms of that planning and preparation. We were also fortunate that we had, I suppose we had invested in external consultancy round about that as well. So for our organisation, I mentioned that we're dealing with quite unpredictable nature and risk at different points. So for us, we always thought it was important that we had different contingencies in place, different plans in place, and I think possibly other people could benefit from that as well.
I don't have any more questions for you. Thank you very much for your time today, but I wondered if there was anything which we hadn't covered which you perhaps thought it was important to raise.
I don't think so. I think we've covered everything.
Nothing else for myself.
No.
Thank you very
Very
much.
good. Sorry. Very good. Can I just join Ms Taylor in saying thank you very much indeed? Could I actually add, Mr Soutar and Mr Warner, that that was a very impressive presentation, and all credit to Kibble. They appear to have coped with the pandemic, no doubt because of the planning in advance, but coped with the pandemic better than many other institutions. Thank you very much.
Thank you.
Thank you.
We'll have a break now till 11:15. Thank you. Thank you, Ms Freedom.
Thank you, my lord.
Now, good morning, Mr. Stephen.
Good morning, my lord. The next witness this morning is Lorraine Mackenzie.
Good morning, Ms. Mackenzie.
Good morning, my lord.
Right, when you're ready, Mr. Stephen.
I'm obliged, my lord, thank you. Could I start by asking you your full name, please?
Lorraine Mackenzie.
Thank you. Your age and contact details are known to the inquiry, so I won't ask you for those. You've helpfully provided a written statement already, and for the inquiry's reference, that is SCI WT 0455 5 zeros and then a 1. Are you happy for that statement and the evidence you give today to constitute your evidence to the inquiry?
Yes, I am.
Thank you. Are you happy for that evidence to be recorded and published?
Yes, I am.
Thank you. Now, everything you said in your statement, even if we don't touch on it today, will be taken into account by the inquiry, so rest assured.
Okay, thank you.
And the last thing I wanted to mention before I start asking you questions is that there is a restriction order in place. Now, the chair has granted a partial variation of that order, which in essence means that we can name your son, but it still applies in respect of any other individuals. So any other family members or other people, please don't mention them by name, but we can talk about your son.
That's
Thank you.
fine.
So you're here today to give evidence to the inquiry about your son. What is your son's name?
David Malcolm Mackenzie.
And how old is David?
He's 45 now.
And I think you say in paragraph 1 of your statement that you've been employed intermittently over the years, but your main job has been caring for David, I think, for around the past 25 years.
That's correct, yes.
Thank you. And I think you also say you haven't really retired because you and your husband are still part-time carers
That's
for
right.
David. Now, before we get on to the pandemic and how that affected David and you, I'd like to just hear a bit more about David and his condition. So I'll start with some questions on that, if I may. In paragraph 7 of your statement, you say that you noticed something wasn't right when David was around, I think it was about 3 months old.
That's correct.
What was it that you noticed at that time?
He was making slight jerky movements, not normal for a baby, and I just felt that there was something not quite right. So I just kept an eye on it and spoke to my GP and started to take a note of when he was actually having these little spasms.
And I think at paragraph 8 you say that David had his first seizure when he was around 6 months old.
That's correct.
After you had testing done, and understand that there was quite a bit of testing went on, what was the eventual diagnosis for your son?
Well, until he reached 19, it was cerebral lesions, which caused him some challenges. And when he was 19, he was diagnosed with West syndrome, which is it's a condition of epilepsy, and it's quite a difficult epilepsy to control. And although he's on drugs, he is quite resistant to the drugs. So he'll never be completely controlled. He will always have seizures.
If we go back to the lesions for a moment, how did they affect, what did they signify? How did they affect David's early development?
Well, his development was delayed, and it took him some time to get onto his feet. I think he was probably near 2 before he was actually able to stand, and he didn't have any speech at that time either. He wasn't producing any attempts to speak, and so therefore that was quite significant and quite a red flag to us as his parents, to know that there was something seriously wrong.
And what did that mean in terms of David's education, for example, as he was growing up?
Well, he had to go to the local special school, which was fairly near our house, and he was there until he was 14. We weren't very happy about the school. It wasn't really providing everything that David needed, so we looked elsewhere for better or improved services, and we actually found Stanmore House School in Lanarkshire, where they had nurses on staff. They had speech therapy, occupational therapy and physiotherapy, which was also very important. So David went to Stanmore House from when he was 14 until he was 19.
Thank you. You mentioned West syndrome, and I was going to come on to ask you about that anyway. I think in your statement you describe it as a complex epilepsy condition. And you said he was 19 years old when David was first diagnosed with that. And you mentioned seizures. How often, typically, if one can say, does David have these seizures, and what does that involve?
I think it's varied at various times of his life. I would say probably once a week. And at the moment, the seizures that he's having are not as severe. So he doesn't require the midazolam as much as he has done in the past.
And how long do those seizures last?
Well, they can last up to 8 minutes. And if they last till 8 minutes, we have to get an ambulance, because by that time we will have given him the midazolam, which is a rescue medication for seizures. And if he hasn't come out of the seizure after a further 5 minutes, we would phone for an ambulance. But we've been very fortunate that he's always come out just kind of at the deadline. So it's great to have the midazolam, and if we didn't give it to him, it would cause him further problems and even death.
And I think you say in your statement, don't you, that it's perhaps a medication-resistant condition, is that right?
It is.
Medication helps, but...
Medication helps to a certain extent, but it will never control his epilepsy. And the midazolam is only given as a rescue medication when he's not coming out of the seizure.
Thank you. And how would you describe David's level of communication, the ability to communicate?
It's quite basic. He does understand what you're saying if you make it quite simple, and you sometimes have to repeat what you've said to make sure I know that he has understood what I have said. So I will repeat the question to him as, do you understand what I'm saying? And he'll either nod or he'll shake his head. And so that's really how we communicate. He does have very good facial expression and body language, and so he's able to express how he's feeling. Sometimes when he doesn't want to do something, he will show you through his body and his facial expression. Or he'll just say no. He can't actually say no. Of all the words, he can say no.
Say no. Nice.
Yeah.
An important one. You also mentioned in your statement that I think David has aphasia, if I'm saying that correctly. What is that?
It's a speech disorder.
Okay. And in terms of his physical condition, you talk about this at paragraph 20 of your statement. You say David has ataxia.
That's correct.
Can you tell us what that is, please?
It's just uncoordinated movement down one side, and it can cause further problems with the spine because he's leaning to one side quite a bit. He's favouring one side. So that can lead on to having other problems like scoliosis and kyphosis, which he has as well.
And does that impede, for example, his ability to move, to walk?
Well, it has impeded his mobility quite a bit. When he was younger, he was able to do an awful lot more, obviously. He could walk about quite the thing, and he could play a bit of football, enjoyed cycling, swimming. It was a three-wheeler bike, of course, because of his ataxia. And he just enjoyed life very much and liked to go and visit friends and family. And so when he was younger, he was much more mobile.
Thank you. And I understand that David lives in supported accommodation, is that correct?
That's correct.
And how long has that been the case for?
20 years.
And he shares that accommodation with others? He's not in...
No, he's not on his own. Okay. We never wanted him to be on his own in supported accommodation for various reasons. And so it's worked fairly well up till now although we do have some issues with the house at the moment, and we're looking into that.
Okay, thank you. Is it paragraph 32 of your statement, I think you described that David receives the complete care package, I think, and one-to-one support. So I just wanted to ask you, I suppose, in broad brush terms, what does that involve, his day-to-day care in that supported accommodation?
Well, he requires help with dressing, showering and dressing, medication, getting his breakfast ready, just getting ready for going out for the day. So he is supported through all that by the support workers, who have been very good. Yep.
And the one-to-one support part, that's with at least one member of staff. And
one member of staff, that's correct. He has the one-to-one support specifically because of his epilepsy and how it's not something that you can ever know it's going to happen. So he always has to be kept safe, and someone always has to be with him, more or less, all the time.
Thank you. And we'll come back to supported accommodation, because I know that's something important that we'll discuss in the context of decision-making by the Scottish Government. But for now, I'd like to ask you a little bit more about David and his personality, particularly prior to the pandemic, and this is something that you talk about at paragraph 23. How would you sum up David prior to the pandemic, his personality?
He had a very happy personality, very tactile, affectionate, very much an outdoor person, just loves going out in the car, and he also has a very good sense of humour, which is surprising when there's a lot of things that he maybe doesn't understand. He enjoyed ball games, going to rebound therapy and swimming with his parents. So we did a lot with him. Although he was in supported accommodation, we were still very much involved with him.
You mentioned rebound therapy there. You'll have to forgive me. I think in paragraph 24 you mentioned that too. Can you explain what that is?
It's just trampolining. Well, I shouldn't really say it's just trampolining because it is a specialised trampolining. My husband and I actually had to do training to be able to take David to the rebound therapy. It's very, very good for muscle control, for coordination, confidence, just enjoyment as well, and very good physically for him, and I suppose emotionally as well, because he always enjoyed it. Thank you.
And I think in paragraph 33 you also talk about David going, at least pre-COVID, to Nordorf Robbins music therapy. Yeah. What would that involve?
Well, he would just be taken to the music therapist, and she would take him through different instruments. He has a particular interest in the piano, and she would play the piano for him and get him to join in. And she would also try him with different instruments. Music's a great thing for people with disabilities, and it was great for David. We really enjoyed going to the Nordorf Robbins, but that's not something that's on offer all the time. It is a charity organisation, of course, but there's so many people that need to go to it, so you can only get it for certain periods of time.
And would I be correct in saying that those activities that you mentioned, and perhaps others, those would have ceased during the pandemic?
Everything ceased. Everything ceased.
Okay, thank you. And I think you also, on the subject of music, I think you also talk in your statement about David playing the piano with you at home. Yes,
he likes to visit us at home, and always likes to play the piano with me. I don't know who's worse, him or me, but he really enjoys it. He enjoys piano music. For some reason, it seems to speak to him, if you like.
Thank you. Now, you've explained that David has lived in supported accommodation, I think, for 20 years, at least 20 years, you said. Prior to COVID, how many times would you have seen David in a typical week?
We would see him at least 4 times a week, I would think, because prior to COVID, we were still taking him to his rebound therapy and to swimming, and we would just pop down to see him and take him out for a run in the car and a wee walk in the park, something like that. Nothing terribly exciting, but we did see him a lot.
And has that arrangement evolved as, well, as you and David have got older? Has that changed over time when he's been in supported accommodation?
Well, of course, and we also, I should have mentioned that we also had David home every second weekend when he went into his house at first. We just felt we had to do that very gradually, and he did settle fairly quickly actually, and we were happy with the situation, but we still felt it was really good to see him every second weekend, and we did that for the first 10 years. And then we felt that as we were getting older, we really had to step back a little bit, which we did. And we went from every second weekend, I think, to once a month. And then we went to 6 weeks when we got to this age.
Which I haven't asked you about, and I'm not going to. If I can turn then to the pandemic itself and the restrictions that were in place. At paragraph 38 of your statement, you mentioned Mother's Day in particular on the 22nd of March 2020. So I wanted to ask you, I suppose, why does that particular date stick in your mind? And just a gentle reminder about the restriction order not to name any individuals when you do. Thank you.
Obviously, it was Mother's Day, and it was the day that we were told that we were not allowed to come back into the house, and that we wouldn't be able to see David, so it was quite a significant date.
Were you told for how long, or what information were you given at that time?
We weren't told, and we did feel very uncomfortable with the whole situation. Actually, a bit of a feeling of dread, to be honest, and we just wondered when we would see him again.
And ultimately, how long was that absence, that gap of contact with your son, physical contact at least? How long did it last?
For the first maybe month or so, we were just Skyping, and then we started to go down to see him at the house, but we were seeing him from outside the house. We would sit outside, David would be in the kitchen, and we would be sitting outside in the garden, and then as time went on, there was a gazebo bought so that David could come out into the garden and we could actually see him in the garden. However, we still maintained distance, we still weren't allowed to touch him, and that was all very difficult.
You mentioned Skype there when you were talking. How did David react to that? Did he understand what that was?
He knew it was us, but obviously he wouldn't understand it the same way as most people would. And we could speak to him, and as long as we kept the language simple and clear, he would be able to respond.
And I think you said in your statement you were talking about garden visits and gazebos. How soon did those start after the restrictions were put into place, do you recall? Because I think in your statement you talk about them almost immediately happening, those visits. Do you remember when that would
Yeah,
have
I think
been?
probably maybe a month or something like that afterwards. But it was like a whole year before we were actually able to see David properly and give him a hug.
Yeah, so during that time there was still no physical contact?
There was no physical contact at all.
Would you have been wearing masks at that time?
We were.
You were, okay. Now I noticed that there's a few points in your statement, paragraph 43, for example. I noticed the word team, and there was a lot of references to you and your husband working as a team, being part of the team or backup team for David. And then at paragraph 40, you talk about being banned, essentially, from David's house as supported accommodation. How did that make you feel, given your role up until that point, when you were then unable to see him or assist David?
I really felt quite bad about it. I felt it was a bit of a slap in the face, considering we had been so available for staff. If there was an absence or somebody was sick, we would just step in and take David for the day or for the night or whatever. And we always considered ourselves as being part of the team, maybe on the periphery rather than the core team. And we've always looked upon it as shared care, really, I suppose. And yeah, we felt very, very, very angry about it, actually, and disappointed. and I don't really know what else to say about that.
Thank you. And you mentioned staff. In your view, did your exclusion or absence from David's care, did that impact upon the staff that were looking after him too, do you think?
I think so, very much so, because staff are sick as well, and so therefore other members of staff are having to take on more responsibility, more care, more physical care, and so I would say at the end of the year that the staff are pretty much on their knees. And that in itself made me angry, because we were sitting there, we would have been able to take David, and, you know, it wasn't allowed.
And did David understand why this was happening? Did he ask you about that?
Well, David's non-verbal,
Yes.
so he obviously understood there was something not right, because everybody was walking about with masks on. And funnily enough, as the time went on, you know, and if someone had forgotten to put their mask on, he would just make the sign for a mask. You know, you have to put your mask on. So he understood that there was something going on in the house, that they had to have their mask on to keep people safe. So that's a level of understanding, but not a total level of understanding.
Yeah. And at paragraph 37 of your statement, I think you describe yourselves as a very close family, very huggy, tactile,
Yeah.
a word you mentioned earlier in your evidence as well. How would you describe that impact upon you and your family of these restrictions at that time?
Well, it was just awful. It really was terrible, and I think we all suffered emotionally, and of course we could see ourselves that David was very, I would say, had a very low mood. I wouldn't say he was depressed, because I'm not a doctor, but I think he very much became quite into himself, quite withdrawn, and when we went to see him, you know, he would make the sign, you know, for a hug or whatever, and we would just say, no, we can't do that today. And he seemed to understand when you said, no, we can't do it today, that's fine. But still, he was emotionally very, very low, as we were.
Yes, thank you. Because yes, at paragraph 59, I think you talk about that, about how you all felt miserable, and you could see that hurt in David's face.
Yeah, absolutely.
At paragraph 60, you mentioned at one point actually considering taking David out of his accommodation altogether. So I wanted to ask you about that. What was your thought process there, and why ultimately did you decide not to?
I think really I was so emotionally low, and seeing how David was, I suppose when you're faced with something like that, your mind goes to different things. And we did consider taking David back home. And then we thought, well, this might cause further problems, further confusion for David. And also there might be problems or sanctions taken against us, because although we are David's parents and his guardians, and we felt we didn't really have any power at all, we had to consider that they might not take David back in. So that would have been very, very difficult, because obviously we were getting to our 70s, and we just felt as if we didn't really want to start going through all that process again. And yeah, so that was, we just kind of left it. But it was definitely a thought. It wasn't just a thought that flitted through my head. It was a real thought, and we did think about it and talk about it, and we decided that for all those reasons that we wouldn't go ahead.
Thank you. In paragraph 58 of your statement, you say that when you were eventually able to see David again, take him out again, you saw a huge difference in, I think, his posture and mobility, and that is something we've heard from previous witnesses in relation to PAMIS and other organisations' posture. What was it in particular that you noticed about David when you saw him again, were able to take him out?
Well, his balance was very poor, and he was walking very gingerly, you know, taking very small steps and holding on to me. And also when the staff were taking him out, they were taking him out in his wheelchair all the time. So we could see that, you know, there had been a decline in his muscle tone, and so therefore his walking wasn't good, his mobility was poor. So.
And do you think there's been a longer term impact upon David's physical health as a result of those limitations?
I think that was the start of his decline in mobility. I can't say for certain that it was all to do with that because of his condition, his syndrome, because obviously the continual epilepsy or seizure activity causes further brain damage, and so that affects mobility, it affects everything really. But I think given that David's mobility was quite good pre-COVID, and that was because he was getting swimming, rebound therapy, walking in the park, lots of different things to keep him mobile, and that was all finished. He was getting nothing, and so that was the result of it really. And of course, to this day, his mobility has not really gone back to how it was pre-COVID.
In paragraph 52 of your statement, you talk about the easy restrictions around 2021, sometime in 2021, and I think you describe the rules as being ludicrous and unnecessary. Strong words. Why do you hold that view?
Well, I really felt, you know, that by that time we'd all been vaccinated. David was vaccinated very early because he was a vulnerable adult, and, you know, we're allowed to take him out, but a staff member had to push the wheelchair. We were wearing masks and gloves, but we weren't allowed to push the wheelchair, which meant that we couldn't really have any time with David on our own. I did sometimes feel that we were being watched, if that's not such a silly thing to say. I think people were very, very aware that perhaps you could do it unintentionally, maybe. So, yeah, we were just, and I just felt that it was silly that, you know, we could just have easily pushed the wheelchair. We weren't in front of David where we would be breathing on him, and of course we had masks on. I just didn't understand it at all. I just thought it was silly.
Thank you. Touched on the physical impact. I wanted to ask you also about whether you think, in terms of mental health, whether there was a longer term impact on David or not of these restrictions.
Yeah, I think it took him a few months to recover. I think he was quite anxious and always had to make sure he knew when he was going to be seeing us again, make sure he knew when he would be visiting us in our own home and when we would be visiting him at his home. And I think that went on for quite a number of months before he felt really quite confident again that everything was okay. So yes, it had a huge impact on him emotionally and physically.
And you talked earlier about the therapy services that David was able to get at least pre-COVID. Since COVID, has there been a longer term impact on those services being offered, activities for David?
Well, I think during COVID, a lot of the therapy companies perhaps had to fold because they couldn't, well, they weren't getting any money in. So they just had to fold. David is now getting back to, he actually goes to the RDA, which is the Riding for the Disabled, but he goes to, it's horse and carriage rather than just horse, and the wheelchair is pushed up onto the carriage and he's taken round a couple of different paths, and he really enjoys that. We're hoping to get back to swimming very soon. David hasn't been very well. He's had 2 hospital visits since we came out of COVID. So he hasn't really been well enough to go swimming, but we're hoping to get back to that as well.
Thank you. I wanted to come back then to supported accommodation, because you talk about this in your statement, sort of versus care homes. And at paragraph 44 of your statement, you mentioned that there was, as you put it, confusion within the Scottish Government about what constituted a care home as opposed to supported accommodation. So I suppose firstly I wanted to ask you, what was that confusion? Why do you think that confusion existed?
I think really there's very little known about care in the community by the Scottish Government because there are a number of different ways of caring for people in the community. A care home is mostly seen as for elderly people, although there are care homes for people who have been born with lifelong conditions as well. But supported accommodation is about care also, but it's care homes and supported accommodation, completely different things altogether. And sorry, could you just repeat the question?
Yeah, of course. I was essentially asking you, why do you think there was that confusion? Because you said there was confusion with the Scottish Government. So why do you think that was?
I feel that the Scottish Government are so far removed from what happens in communities, and there's just never been very good services for people with lifelong conditions. And although I and other mothers and fathers have been part and very proactive in different organisations to try and let the government know about different things, it has fallen on deaf ears, I think. I just don't understand why they don't listen.
I'll come back to that. You talk about it being a huge problem, this failure to distinguish between supported accommodation on the one hand, care homes on the other, and you've talked about how there's a variety of different care settings. Why, in practice, was that a huge problem at that time, this failure to distinguish, as you see it, between supported accommodation on the one hand, care homes on the other?
Well, when they were starting to come out of COVID, the lockdown, there was a group set up. It was mainly civil servants, and they were talking to people who had relatives in care homes. And I was invited to go along to the group, and it became very clear straight away from the terms of reference for the group that there was no mention of supported accommodation. So I did raise this issue on a number of occasions, at different meetings, and asked if they could expand on the terms of reference. And here again, I just think it just wasn't acceptable. It kind of fell on deaf ears because I think the civil servants were asked to look into the care homes. So supported accommodation was never actually referred to, which I think is quite alarming because there's many supported accommodations right across Scotland. So I actually came out of that group because I was actually quite annoyed and felt that I hadn't been listened to. They really just didn't want to know.
And to be clear, this is the Clinical and Professional Advisory Group. You talk about this at paragraph 65 of your statement.
Yep.
And this was a Scottish Government created group, is that correct?
That's my understanding, yes.
Right. And do you understand what the role of that group was, what it was there to do?
It was to listen to the care home relatives because they were very insistent on trying to get a new law passed called Anne's Law. And so therefore that was part of the whole process, I think, to listen to the relatives. And then I suppose from there it would go to the Scottish Government, and then whatever happens after that. I had actually also written to the First Minister at the time and also to the Health Minister during that first year when we were not allowed to see David at all. And I got an acknowledgement from the Health Minister's team, but I had no acknowledgement from the First Minister at all. And in that letter, I had outlined my reasons for asking the government to think again about keeping parents away from their children. So that was another disappointment.
Yes, this is paragraph 46, I think, of your statement. You
Sorry,
talk
I've
about
just
writing these.
jumped the gun.
No, it's absolutely fine. It's your evidence. Yes, and so those letters, as you say, you made your views known. What specifically were you saying then in those letters to government?
I was just trying to outline that the complexities of the conditions that my son and others had, and how their parents had been very involved with their children, and that this was a really, I didn't say cruel, but I did think it was quite a cruel way of keeping parents and children apart. Just try to explain that it would do them no good, especially mentally, emotionally, etc. But there was no reply.
Do you remember when you would have written those letters? They might have been written at different times, but do you remember when they were sent?
It was, I think, it would be 2020, because it was 2020 was when we started in the lockdown. So a couple of months after March, probably May or June, I think it might have been, I sent both letters. And
in respect of the First Minister, you received no reply?
No reply.
And in respect of the Health Minister, you had an acknowledgement,
I had an acknowledgement,
but
no further action.
All right, thank you. Going back to the
group.
group...
I'm right in saying you've provided copies of these letters to the inquiry, Mrs. Mackenzie?
Pardon?
I think I'm right in saying you've provided copies of these letters to the inquiry?
Yes, I did. It was actually just one letter.
Yeah, I'm very grateful for that. Thank you.
Thank you.
Thank you, my Lord. Going back to the group that you were talking about, the clinical and professional advisory group, you say, I think, the feedback you were giving fell on deaf ears.
Yeah.
Again, why do you think that was? Because from what I understood from your evidence was this group was created to hear the views of those with relatives in care homes. Why do you think your views were not being listened to at that time?
Because they didn't understand the difference between care homes and supported accommodation. And their brief from the government was to look at care homes. That's my understanding of it anyway.
Because yes, at paragraph 67 of your statement, I think you say they being the Scottish Government, were not listening, and they really have no understanding of how our sons and daughters process information or how their lives are and everything that goes with that. So I suppose I'd like to ask you, how would one rectify or improve that understanding, in your view?
Well, I've often said that politicians should do a shift in a care home or in supported accommodation, because you can tell people what it's like, but until you're actually doing the job, you know, it's a totally different thing. So, yeah, I think politicians are far removed from the actual care in the community. They don't understand what it takes to care for someone over a 24-hour period. So that's my thought.
Well, indeed. So in terms of Scottish Government decision-making, which is of course what the inquiry is concerned about, how could that be improved? I mean, could consultation be improved, for example? Are there parties or individuals you think that should have been listened to that weren't? What would you say to that?
Well, I think the wrong people are involved, to be honest. I do think that the third sector should be far more involved in decision making, because the third sector, like PAMIS, they are the people who understand the situation. They know about lifelong conditions. They know what is needed to support these people. And I just feel that they would do such a good job if they were involved at the highest level of decision making. I would like to see that, and perhaps also some parents who have, you know, lived with the issues for many, many years and continue to do so.
And in your view, that was something that would have been lacking at that time during the pandemic?
Oh, it was very much lacking.
Thank you. You mentioned Anne's Law, and that was one thing I wanted to come to, really the final thing I wanted to come to with you. And at paragraph 65 of your statement, you say that it's vital that people in supported accommodation can see their family members. And at paragraph 49, you remarked that there was a lack of common sense applied to the policies and decisions that affected our lives. And you draw a distinction, I think, there between, I think, you as a family being at home, perhaps except going out for grocery shopping, and those who were looking after David, rotating staff, going back to their families, going on public transport. And I think you described that situation as nonsense in fairly blunt terms at paragraph 63. So in respect of care homes, this inquiry's already heard a lot about Anne's Law. Is that something that you would favour being mirrored in respect of those like David that are living in supported accommodation?
Yes, I would very much like to be part of Anne's Law, if that could be included, because I believe that Anne's Law has gone somewhere in Parliament already. I don't know exactly where it is, but rather than making it a new ruling or anything like that, perhaps there could be a clause or something that would include people like David who have been born with lifelong conditions, and then we would never be in this position again whereby we would have to do without seeing our children, our adult children, or in the case of the care homes, seeing elderly parents, and I do feel that it was a terrible thing to do to care homes as well. Care home relatives, I should say. But yes, if that is something that could be done, I think that would be very sensible, and would just to be included.
Thank you. I don't have anything further to ask you, so I think if there's anything else that you think that we've missed or that you'd like to emphasise, whether that's lessons learned or otherwise, then obviously be grateful to hear that now.
Okay, I do have a list here, but I think most of it has been covered. I do think to facilitate real change, the government has to have a mind change of attitude. I think perhaps they don't realise how experienced we as parents are and how much we could bring to any decisions that are being made. So we have, so I suppose my overall hope is that we could be included in Anne's Law, and that there will be some taken to ensure that this group of people will see some positive action in future, and we will never be in this situation again. You know, so that, I think that's really all I need to say. Just to finish, to ensure that this happens, we need a dedicated set of people who know what they're talking about and have the authority to make appropriate changes. We don't need further consultations. We've been consulted up to the eyeballs, basically. And so if they don't know what's needed by now, they haven't been listening. So I think that has always been the key for me. People have not listened. So I'll just leave it at that. Thank you very much, Mr. Stevens.
Thank you. And thank you for telling us both about your son and obviously your own perspective. So thank you very much.
Thank you.
Yes, thank you, Mrs. Mackenzie. May I say that was very powerful evidence. I'm very grateful for the efforts you've put in coming into our visit.
Thank you, my lord. I'll just go. Can I just go?
Yeah. Right. Now, we finished a bit early again, Mr. Stephen. However, the next witness, I understand, is remote, so I don't think we can do anything about changing the time of that. So I'm happy to give you a long lunch break, 1:30.
Thank you very much, my lord. Thank you.